Well, I think we'll go ahead and get started. And I know we're going to have some other folks joining us throughout the morning, but just as I said yesterday, again, today, I'm just excited to see so many of your faces. We have some new folks joining us today, and some of you, most of you, I think, were able to join us for most of the day yesterday. So welcome back. A few reminders and housekeeping things. We do ask that you stay on mute. But we will have a chance for question and answer at the end of each session. And then at the end of our day, we're going to have a chance for networking too at 11:30. So there will be an opportunity for you to connect with others this morning as well. We will have a break at 10:15, but feel free to step away at any point if you need to. And if you're like me, you've got your Saturday morning coffee with you. So we just hope that you'll be relaxed and enjoy the sessions today. Just to recap yesterday, for all of us that were there, I think we were incredibly inspired by Heidi's story and the White Ribbon Project. I see some white ribbons in our pictures right now around the room, but incredibly inspiring and very powerful to hear Heidi's story. And then we also talked with Dr. Garst about reflections during the pandemic and just kind of the current state of the lung cancer community and some of her observations. And then we talked a little bit about resources that lung cancer patients need and how we can advocate for those and how patient advocates do that and patient navigators. And then we ended the day, of course, talking about the power of our stories. And that's kind of the theme, is what can we do? So today we are going to arm ourselves with tools about new treatments, new strategies in treatment, biomarker testing, and survivorship. And then at the end of our day, Colleen's going to help us pull it all together and talk about next steps. What can we do as advocates? So with that, I'm really excited to kick off today with someone who I think most of you probably know. She is our founder and president of Lung Cancer Initiative, and her inspiration and her commitment are infectious. You can't meet Amy C. Powell and not be inspired and want to do something for those that are impacted by lung cancer. So Amy is going to share some of her perspectives this morning and get us kicked off. So Amy, I'm going to turn it over to you.
Thank you, Paige. And I'd just like to give a shout out to Paige and Jenny and Colleen and all of the staff and all the hard work they do to pull this summit together and all that they do all day long. They always give me kudos, but I've been sitting back and letting them do the heavy lifting for many years now. So anyway, they're a wonderful group, and it's wonderful to see all your faces here this morning on what I call an early Saturday morning. Apparently not everyone calls it early, but in any way, it's just really good to see so many advocates come out for the cause. When we started the organization back in 2007, we had a very ambitious mission, which is essentially the same as it is today. And we realized, and there were literally a handful of us, and many of us who are still involved here with the organization still through today, through all the years, which is kind of nice to see. But we realized at that time, if we wanted to achieve that mission, that we really needed to grow our network. That was our first objective, was we really needed to grow and get more people involved with us. And we've done just that, as evidenced by, how many of you are involved today and all that we've done. So one key change that we've seen over the past, 14 years, and I'm amazed it's 14 years, is the number of survivors. Thanks to better screening and treatments and frankly advocacy, we've seen the survival rate grow from, it was hovering around 15% when we started back again over a decade ago, and hadn't budged in years. And this year we saw the announcement that it's up to 21%. And while that still is too low, that is huge progress. That is a lot of lives saved. And so it was interesting to me. Back again, 10 years ago, we would have never thought of having a theme for this particular advocacy summit around survivorship. And now, I think we had something like 43 survivors registered for this summit. I mean, wow, that's a lot of survivors. So in fact, we also had to modify or update our mission statement recently to not just saving lives, but advancing survivorship. So that's a good problem to have. It was not an opportunity that we had, again, when we started the organization. So whether you're a survivor or here, like many of us, because we've lost loved ones to the disease, what we're all working towards is more lives saved and better quality of lives so that other families don't have to go through what so many of us have. And we are accomplishing that here at the Lung Cancer Initiative with your help through research, education, and access, which you've heard a lot about yesterday, and as Paige said, you'll hear more about today. So really just thank you all for being here, for getting involved, for taking action, and for changing the outlook for lung cancer. It won't happen without all of us, raising our voices to make a difference. So with that, I'm going to turn it over to what you're all here for this early morning, and that's to hear our first speaker of the day, Dr. Carrie Lee. She is an associate professor in the Division of Oncology at UNC Chapel Hill. Her medical practice focuses on providing cutting-edge treatment options and compassionate care for lung cancer patients. As the medical director for UNC Lineberger's Clinical Protocol Office, Dr. Lee provides oversight for the clinical trials that investigate novel cancer therapies. So we're honored to have her here with us today. And with that, I'll turn it over to Dr. Lee.
Thank you, Amy, for the introduction. It's an honor to be here. Would it be okay if I shared my screen so I can get my slides up here? Let's see, give me just a minute. You might see a picture of my puppy.
Oh.
So I'll just jump right in. Amy, thanks again for the introduction. It's really an honor to be here. And thank you, Tama, for making the connection between the work that I do and the Lung Cancer Initiative. I'm just going to start off by telling you a little bit about myself. I have been taking care of lung cancer patients for over 15 years now. And like Amy pointed out, really, it's a whole different ball game today. We had a much different mindset 15 years ago with fewer treatment options, less what I call personalized medicine options, and less biomarkers, which I'll talk about as we get into this talk, that could help us select individualized treatments for patients. And this is because of research and clinical trials. And as Amy was talking, it really, a light bulb went off in my head, and I thought, and it's about education and advocacy as well. There's an incredible amount of new hope for patients with lung cancer. And so today I'm going to talk about some of the most recent developments in treatment options for lung cancer. I cannot possibly cover it all. And this was actually kind of a hard talk to pull together in 30 minutes. I'm going to try to be cognizant of the time because as I was sort of gathering my notes to prepare what I would speak about, I kept coming upon another thing, and then another thing, and then another thing. So there's just so much. I think in this talk alone, I'm going to mention 8 or 10 new treatment options just really in the last year or so that have advanced survivorship for lung cancer. And one thing that I'll say up front, and I tell all my patients in clinic, is you may hear some statistics. You may Google them yourself. You may hear another provider or a friend or whatnot talking about them. But I don't want folks to get too focused on statistics or too hung up on statistics, because really the only number that matters is you. We use statistics to help us make informed decisions as lung cancer care providers, but they're not applicable to individuals, okay? So with that said, I am going to spend some time just doing some basics about non-small cell lung cancer, broken down by stage. We'll talk about a new treatment option in early stage disease, give you some updates on treatments that are helping patients with cancer that has spread to the lymph nodes deep in the center of the chest, survive longer and live longer. We'll also talk about a whole myriad of new treatment options in later stage non-small cell lung cancer. And then the last few minutes of the talk we'll spend on small cell lung cancer.
Dr. Lee, I just wanted to check in and I don't know if you're trying to share slides right now, but we're not seeing any slides if you are.
Oh no, I have been showing slides.
Oh no.
Hold on.
And Jenny has them pulled up if you're having trouble sharing your screen.
Gosh, you'd think after 12 months of Zoom meetings, this would not be an issue, but I'm so glad you spoke up.
Well, I'm seeing a white screen. Is anyone else able to see Dr. Lee's slides?
This is really unusual. I got my screen shared. I'm hitting the, how about that?
I'm not seeing anything.
Okay, well, that's exactly why we had sent slides to you earlier. So why don't I stop? Well, let me try one more time. This is irritating. Hold on, hold on.
Okay, yeah, we're seeing slides.
Okay.
There you go. Thank you.
This is a real life example of don't give up, persevere. So I mentioned we're going to talk about some basics just to get ourselves started here and make sure that everybody's sort of starting from the same point. So non-small cell versus small cell lung cancer. So non-small cell is far and away the more common type of lung cancer. We only have small cell lung cancer accounting for about 15% of lung cancer cases, and the non-small cell cases are made up of subtypes based on what the tissue looks like under the microscope, called adenocarcinoma, squamous cell carcinoma, and then a larger cell carcinoma variant. And just basics about staging. Generally speaking, stage 1 lung cancer refers to small tumors that are just isolated in the lung tissue. Stage 2 lung cancers, those tumors may be a little bit larger and they may have spread to lymph nodes or further out in the chest. We call those the hilar lymph nodes. Stage 3 lung cancers, the lung tumor may be a little bit larger, invade some structures in the chest, perhaps an airway or a bone, or involve the lymph nodes deeper in the middle of the chest, called the mediastinal lymph nodes. And stage 4 lung cancer means that it has spread to other organs, or that it involves fluid on the lung that we call a pleural effusion. So this is the oncologist's cancer fighting toolbox, much different than when I started doing this 15 years ago. We now have sort of 3 buckets of treatment, and this does not include the radiation oncologist toolbox or the surgeon's toolbox, but just the tools that myself and my colleagues in the medical oncology space have. We have chemotherapy, which you notice it's got its crosshairs set on all types of cells there. That are rapidly dividing. It's not specific for cancer cells, which is why we see more side effects with chemotherapy. If it affects rapidly dividing cells like the bone marrow, so we see lowering of blood counts, or hair is a rapidly dividing cell, so we may see hair loss. Some of the limitations of chemotherapy is that cancer doesn't always respond to it. And as I mentioned, it's not specific, or it can develop resistance over time. And then moving across the screen, we've got a whole new bunch of tools in our targeted therapy toolbox, where those crosshairs are focused on specific targets on cancer cells. Almost invariably, cancer cells develop resistance to targeted therapies, but they can work for sometimes, and actually not too uncommonly, for years. The side effects of targeted therapy are a little bit different. Some are really, really well tolerated. Some of the more common side effects are diarrhea and skin rash, but these can be easily, or relatively easily, managed with supportive care interventions. And then I'm sure you've heard a lot about our new immune boosting therapies. And these are therapies that stimulate the immune system, our own immune systems, to be revved up to attack cancer cells. Side effects of immune therapy, not surprisingly, the immune therapies are also not entirely specific for cancer cells, so they can cause what we call autoimmune side effects. The immune system is stimulated to such a degree that it is affecting normal tissues, most commonly the skin or the intestines or the joints, and we can get what I refer to in clinic as the itises: inflammation of the skin, dermatitis, inflammation of the joints, arthritis, anything, put an itis on anything, and the immune therapies can do it. They tend to be expensive, but usually not much trouble getting insurance companies to pay for them. And we know that there's a differential, not everybody responds exactly well to immune therapy, and it has to do with a specific marker called PDL1 that I'll talk about in a moment. A little bit more basic. So back then we thought about non-small cell lung cancer as one disease. Just as I was coming into practice, we learned that it mattered whether it was a squamous cell or a non-squamous cell, or mainly adenocarcinoma when we're talking about non-small cell lung cancer. Histology matters. That's what it looks like under the microscope. And those differences in histology can guide treatment options. Beyond histology, when we look at the specific subtype of adenocarcinoma, moving further to the right across the slide, there are a bunch of different mutations in the tumor DNA that we're now aware of that can be targeted. Treatments can be developed that target these specific mutations and can lead to really impressive benefit and improvements in survival. So one of the main differences between a normal cell and a cancer cell is that when a normal cell has some damage in its DNA or its genes, it recognizes that and it dies. That's what apoptosis means at the bottom of the pink cell. But a cancer cell, when it has one of these driver mutations that we have identified, those driver mutations can cause the cell to divide continuously. Without undergoing cell death. And these mutations are what we target with all of the targeted therapies that I'm going to speak about in a few moments. And then I will also mention the critical nature of getting a tissue biopsy at diagnosis. We can't just go with a non-small cell lung cancer diagnosis or a lung cancer diagnosis. We need to understand whether or not it's squamous cell or non-squamous cell. And even beyond that, we need to understand to the extent that we can, all of the possible mutations in the tumor DNA. And I tell people this is not about understanding the mutations in their DNA that they pass down to their children. This is just the lung cancer DNA. And we do this broad DNA testing in all adenocarcinoma patients and in some squamous cell patients as well, especially in the squamous cell lung cancers that occur in young people, never or light smokers, or if the biopsy specimen is very small, or if it has a combination of adenocarcinoma and squamous cell carcinoma in it, which we sometimes see. We also need that biopsy to understand the PDL1 expression, which is the marker that we use to guide, to help us understand whether or not the lung cancer will respond to immune therapy. And you can't learn that really any other way than a tissue biopsy. So tissue is very important. This, I think, is a really neat new advance in lung cancer, and that is the liquid biopsy. Okay, so I use this all the time in clinic, and a liquid biopsy means just that we ask patients to give us a sample of blood. Because the tumor can shed cells and fragments of DNA that can be assessed by the laboratories that also do the tissue testing. They can do this from the blood and help us understand the DNA profile just from blood alone. It doesn't help us understand PDL1. It doesn't help us understand whether it's squamous or non-squamous, small cell or non-small cell yet. But it can help us understand those DNA mutations. And this is really important. Can be done, sometimes we do it at diagnosis, and sometimes we do it when patients have been treated with a targeted therapy and then develop resistance to that targeted therapy. It's really minimally invasive, obviously, and very accurate. When we find a mutation here, we can believe it. The one limitation is that if I come up with nothing, I can't believe it, because it may just mean that that person doesn't have a lot of tumor cells in their bloodstream or a lot of tumor DNA in their bloodstream. And so we need to, in that case, more thoughtfully think about where a patient might be safest to have a new biopsy obtained. So we don't believe a negative, but we can be very confident when we have a positive or we detect a mutation. So let's move into some new treatment options for lung cancer. I'm going to start with early stage non-small cell lung cancer. So many of you may know that when a lung cancer has been completely resected or removed surgically, we oftentimes offer patients what is called adjuvant chemotherapy. Then adjuvant means an adjunct to surgery to try to help the patient have longer time without that tumor recurring or spreading to other organs. And chemotherapy has been studied in a bunch of different studies. There was a big combination study called a meta-analysis that looked at data from over 4,500 patients and showed when you give these people chemotherapy after removal of their primary tumor, you can improve survival. But the absolute benefit in survival leaves something to be desired. It's only about 5% at 5 years. And I'm going to show you a lot of these survival curves, and we're sort of focused on the difference or the space between the two lines on the curves. Everyone that I'm going to show you is going to show a new treatment option that works better than the old treatment option. So we're kind of focused on the top curves here. The benefit is in the yellow curve over the patients who did not get chemotherapy in the blue curve. So we're starting to move or consider moving targeted therapies into the early stage setting. Targeted therapies have historically lived in the later stage lung cancer settings. One mutation, the most common mutation, well, not the most common mutation, but one of the more common mutations that we can target in lung cancer is called an EGFR mutation. We have treatment options for this in the metastatic setting or once it has spread to other organs. There was a study that was done called the ADORA study. Don't get lost in the details, but this is patients who had early stage resected lung cancer. They had the EGFR mutation. They were offered chemotherapy if it was appropriate to give them, because that is the standard of care. Okay, and we don't withhold that from patients oftentimes in clinical trial design if there's a really good rationale to give it. So they got their chemotherapy if they qualified for it and they wanted it. And then after the chemotherapy, they were given a 3-year course of either the targeted therapy, which is called osimertinib, you may know that as Tagrisso, or a placebo. And it was okay to give a placebo in this trial because the patients had already gotten the standard of care chemotherapy or the option to receive that. And they received the Tagrisso for 3 years, or as long as they could, yes, for 3 years. If they could tolerate it that long. And then we looked to see how well was cancer controlled at these different time points. And the time points are on the horizontal line, 12 months, 24 months, 36 months. You can see the dotted light gray vertical lines kind of lining up with those. And then the patients who received the Tagrisso are in the teal line on the top. The patients who received the placebo are in the orange line. The amount of time that the cancer was controlled in the patients who received the Tagrisso was significantly longer than the patients who received the placebo. Much more patients at these different time points had disease control with the receipt of Tagrisso. So the FDA approved Tagrisso or osimertinib as an option in this patient population a couple of months ago in December of 2020. In the medical oncology population, or in the medical oncology world, this has now prompted us to test for EGFR in earlier stage lung cancer patients. We hadn't done this before because we didn't have a reason to, but now we do. So in some patients, we're now offering Tagrisso after removal of the lung cancer. What's not clear is whether this will benefit survival. These are the survival curves with the data up to date. And so it's not clear that there's an improvement in overall survival with the addition of Tagrisso, because Tagrisso can be given later. If a patient who has an EGFR mutant lung cancer has it resected, they get their chemo, go on their merry way, and then run into a trouble later, years later, where the cancer recurs, they can be given Tagrisso at that time. So it's not exactly clear if the Tagrisso will improve overall survival, but many would say, as a cancer patient, if I don't have to deal with my lung cancer recurrence, even though I could be treated with this later, that's important to me. And I want to be considered for treatment with Tagrisso earlier rather than later. So this is a very personal decision between a lung cancer doctor and their patient, but it is a new treatment option. Now I'm going to move into stage 3 non-small cell lung cancer. Stage 3 means that the cancer is large or invading a structure in the middle of the chest, and especially the lymph nodes deep in the chest called the mediastinal lymph nodes. So this is a clinical trial that you may have heard about. It's called the Pacific trial. It was a huge game changer in the treatment of patients with stage 3 lung cancer. I'm going to briefly review it and then tell you what we know that's new. So these patients with stage 3 lung cancer, the classic treatment is a combination of chemotherapy and radiation. And then this Pacific trial, after the patients had received their standard of care trial, randomized patients to either the immune boosting medicine durvalumab or placebo for a year. And the patients who received durvalumab did significantly better, had better disease control, and we see improved survival. What's new about this is now we have survival data going out to 4 years, showing that the survival benefit is durable. So the 4-year mark at 48 months, the patients who received durvalumab on the top versus the patients who received the placebo, significant difference there. So durvalumab has long-term benefit. This is the whirlwind part of the talk because there's so much new in the targeted therapy space in the stage 4 setting. So remember, we talked about all of these different mutations that we can detect, particularly in the adenocarcinoma variant. Here are some of the new treatment options. Well, before I get into the new ones, we have a whole bunch of targeted therapies that are already approved for these different, more common mutations that we're able to detect in non-small cell lung cancer. I was putting this talk together and got the alert yesterday that a new drug was approved yesterday for a specific type of EGFR mutation called EGFR exon 20. A new therapy is approved in that space called amivantamab. So I had to add that on. And then a poziotinib drug, also that EGFR exon 20 space, was fast tracked just a couple of months ago as well. So it's like, this reminds me of, if you're from Ohio, maybe a lot of other people say this too, but if you don't like the weather, just wait. You know, there's so much new going on. It's like, just, I tell patients, you know, you don't look at the data because they're the survival data. It's going to be different by the time your cancer progresses, if it does. So always new tools in the box. So some highlights here in the interest of time. A few new things in the ALK positive space: the MET exon 14 skipping mutation, RET fusion, which is near and dear to my heart. My husband's mother was a never smoker who had RET fusion, unfortunately, at a time when we didn't have targeted therapies. So I always think of her when I talk about RET fusion. And then really exciting news in the KRAS space, which is a mutation that we have historically been just stumped by. And now we have hope in that space. So I mentioned I'd talk about ALK. Tremendous overall survival gains in the ALK positive disease. I don't focus on what does this mean for me, just think about it as a population. Okay, so this is a survival curve from some data that were published within the last year and a half or so, looking at the median survival for patients who have metastatic ALK positive disease. Some of them even have brain metastases. The median overall survival time from initial diagnosis is 81 months. That's almost 7 years. I have a number of patients in my practice with ALK positive disease, and this sort of took my breath away, thinking about a median survival of 7 years. Certainly some patients don't survive 7 years, and there are many others that will live longer than 7 years, but that's a pretty impressive number in a metastatic lung cancer population. And also important to understand that these drugs in the ALK space have really good, some of them have really good penetration into that sacred CNS or central nervous system brain space. And so even the presence of brain metastasis did not influence the overall survival. So I consider this very good news. A new option that we have in the ALK positive space that was approved a couple of months ago is a drug called Lorealtinib. This drug has been a treatment option for patients who have progressed on other ALK positive drugs for a while, but now we have new data from a trial called the CROWN trial. It's a phase 3 or an advanced clinical trial with a lot of patients in it. And Lorealtinib was compared to an older drug called crizotinib, and just focus on the difference between those two curves. Lorealtinib significantly outperformed crizotinib with regards to being alive and without disease, and also control in the brain. My standard of care for patients with ALK rearranged or ALK positive disease is usually a drug called alectinib, which I'm not going to talk about very much right now. The Lorealtinib has not been compared head to head with alectinib, but excuse me. So I can't say that Lorealtinib would be better than alectinib, but there's a couple of special points about Lorealtinib, and that it has a really excellent activity in the brain. So does alectinib, but Lorealtinib significantly impacts the disease in the brain. It's got a couple of unique side effects, one related to the lipids, and another related to neurotoxicity, which can be a little tricky to manage. And that is like mood changes, maybe some memory or thinking effects that we have to be aware of as practitioners when we use Lorealtinib. But good to have another frontline option in specific patients, maybe those who have a lot of disease in the brain. I'm going to show you a bunch of these going forward, so I just want to give you a brief overview of what a waterfall plot is. It looks like a waterfall. So we've got 2 of these on the right. And what they show us, I think, very, very well visually is tumor response or tumor shrinkage. So the horizontal line going across the middle of a waterfall plot is like you gave the drug, and this was the baseline. The tumor was static there. Any patients below the line have response or shrinkage of the tumor. That's why all the numbers below the line are negative. And any patients who received the drug and the tumor grew or it didn't work are the patients above the horizontal line. So the more we see under the line, the more activity the drug has, the better the tumor response. And I mentioned this before, that I tend to use Lorealtinib more so in the space where patients have progressed on other drugs in this space, because Lorealtinib has great activity in patients who have progressed on other ALK-targeted therapies, as referenced by this waterfall plot that shows all these patients responding under the line, and also response in the brain. Okay, so moving on, another mutation that we can see in non-small cell lung cancer is called a MET exon 14 mutation. We have a new drug in this space that was approved exactly a year ago called capmatinib. Look at the waterfall plots. The ORR means overall response rate. An overall response rate of 68% is wonderful. And there's more, I don't think I have it on the slide, but there's likely an even higher disease control rate. So that's a new drug. There's a second drug in the MET exon 14 space called topatinib. Topatinib works very well as well, approved by the FDA in February of 2021. These drugs, I've used them in a couple of patients. They have an annoying side effect of fluid retention. So they tend to be, patients who take these drugs are most challenged by fluid retention, and we try to help make them more comfortable with different strategies there, but it can be challenging. That said, you know, they have a nice response to the drugs often, and it spares them the need to take chemotherapy. 2 drugs in the RET fusion space. One comes out of a trial that we ran at UNC called the Libretto trial. In the RET fusion mutation, patients were treated with a new drug called percatinib, and you can see all of the responses under the line there. In patients who had never received other therapies, the ORR, overall response rate, was 85%. And this drug tends to control the tumor for a very long time, approved by the FDA last year. And then a similar drug in that space approved in September called Proseltinib. percatinib, in the RET fusion space, nice response and durable response as well. I want to pause here and take a breath because KRAS has been like the bane of our existence. It's one of the most common mutations in lung cancer, period. There's a specific variant called the G12C that we're finally chipping away at. The G12C, oops, I have a typo there, but it makes up about 13% of the mutations in non-small cell lung cancer, can be associated with resistance to targeted therapies and be very difficult to treat. When KRAS is normal, like on the left side, the signaling is, as you might expect, that cell is sending messages to the nucleus via chemicals and a non-highlighted, non-overactive state. But when the KRAS is mutant, it's like, thunderstorm of signaling being sent to the nucleus of the cell, causing it to grow and divide, go and divide. So we've got 2 new potential treatment options in this space, not approved by the FDA yet, and I hope it's not long, but we have a drug called Survivorship that was studied in a grouping of patients with advanced solid tumors, but specific in the non-small cell lung cancer patient population. We can see lots of patients under that horizontal line with either stable disease or partial response of their tumors. The overall response rate was about 32%, but the combination of those patients who had a complete response, a partial response, or stable disease, that's what we call the DCR or disease control rate, was 88% of patients. So that's really good news. And then another drug in that KRAS G12C space called adagrasib, with a response rate of 45% and a disease control rate of 96%. So this is really good stuff happening in the KRAS space. Only got about 5 minutes left, so I'm going to run through this rather quickly. But for those non-small cell lung cancer or small cell lung, any patients who don't have an actionable mutation, what do we do for them? The hope is not only in the patients who have actionable mutations. We have success very often with immune therapies in this space. And the way immune therapies work, I'll try to explain this very simply, is we look at this tumor cell, the yellow cell, in the upper left-hand corner of the first block. And then the immune cell. When the tumor cell expresses this PDL1 marker, the immune cell locks into that. And this connection is a checkpoint, and it tells the immune system to leave the tumor cell alone. It's like a special invisible shield for the tumor cell. But when we use drugs that block this interaction, PD-1 inhibitors, PDL1 inhibitors, there's also another class of immune therapies called CTLA4 inhibitors, which I won't get into here. We're just going to focus on the PD-1, PDL1. But when that interaction is blocked by these PD-1, PDL1 inhibitors, then the T cell can attack the tumor cell, and you see it sort of cracking up there, breaking down in the right panel, upper left-hand corner. So that's how these drugs work. And there's a lot of success in this space. We know that patients with advanced lung cancer who receive chemotherapy have benefit with the addition of immune therapy. We don't have time to go through all of this, so a lot of it is not new per se, but I just want to highlight this space. And then on the bottom of this slide, you see nivolumab plus ipilimumab in advanced non-small lung cancer. In some patients, there's a chemo-free option. We in the thoracic oncology world are kind of kicking around how we're going to use this information and what patients it might matter for. I don't tend to use it very often, frankly, but there is, for the patients who feel very strongly about not receiving chemotherapy, an immune therapy option that might make sense for them. Last couple of minutes, small cell lung cancer. Small cell lung cancer has been pretty static for a while. I entered this space in the early 2000s and was sort of living the 1990s. Everybody gets what we call platinum-based therapy with a carboplatin or a cisplatin combination. And we have learned, just like in the non-small cell lung cancer space, that the addition of those immune therapies can have real benefit in patients who have small cell lung cancer. So I'm not going to talk about that today. Immune therapy has worked its way into the standard of care. Just wanted to tell you very quickly about two new things. We haven't had a new drug other than the immune therapies approved for small cell lung cancer in quite some time. This is a new option after patients have progressed on their frontline therapy approved by the FDA in June of 2020. It's a medication called lurbinectedin. The response rate was 35%, and it tended to be a different response rate, whether or not the patients had previously responded to their initial platinum therapy or they had resistance to the initial platinum therapy. Not surprisingly, it didn't work quite as well in the patients who had likely a more aggressive disease, meaning they didn't respond to their initial platinum-based therapy. But I use this in clinic, and it's nice to have another option in the second line. It's a chemotherapy medicine that's given once every 3 weeks by vein. And then lastly, we focus on, how do we hit the how do we hit the cancer, new drugs that attack the cancer. But we also have to keep in mind that it's important to develop new drugs that improve the quality of life of our patients and make the chemotherapies or the immune therapies or whatever more tolerable for patients. So this is a new first-in-class bone marrow protective agent called trilaciclib that was approved by the FDA a couple of months ago in February. And it works we talked about how chemotherapy targets rapidly dividing cells, okay? And the rapidly dividing cells also include those in the bone marrow. Chemo attacks them, people have low blood counts, sometimes need transfusions, may run the risk of fevers with low blood counts and that sort of thing. What can we do to minimize that? So in the small cell lung cancer patient population specifically, we have a new drug called trilaciclib that actually arrests the normal cells, like causes them to pause for a little bit so that the chemotherapy isn't so interested in them and they can survive the chemotherapy. So this new drug was approved, and it helps patients have a better quality of life because they don't have as much fatigue related to low blood counts. They don't see as much dropping of the white blood cell counts. They may not need as many transfusions, that sort of thing. So that's an exciting new development to have in the toolbox as well. And there's more. I'm out of time, but there's more targeted therapy. There's more immune therapies being developed because not everybody responds to the PD-1 targeted drugs. And there's new drugs with different mechanism of actions. One of them is called an antibody drug conjugate, which means that we use like an antibody, which can recognize a marker on the surface of the cancer cell and like deliver the chemotherapy or the payload directly to that cancer cell rather than having it float around everywhere in the body and influence the normal cells more severely. So I have to stop there, but I would just say there's a lot more out there. Thank you for your attention and the opportunity to spread hope today. I had the opportunity to be at the podium to be your teacher, but really more so, you all teach me. I learn from you every day in clinic. I'm humbled by your courage and this disease and this profession. So with that, I'll stop. Thank you.
Dr. Lee, thank you so much. You did such a wonderful job communicating all of this science in a way that definitely was manageable for us to understand. And we have a lot of great questions. So we're going to spend a little bit of time doing Q&A before we move on to the next talk, if you're okay with that.
I can try. Yeah.
Yeah, great. Okay, I have a list here so I can run through it with you. So first, this was about the Tagrisso trial you were talking about. Can you comment a bit more about the use of placebo versus the standard of care in lung cancer trials?
Yeah, I had a feeling that might come up because I tell patients when I consent them for a clinical trial that we usually don't use placebos. 9 times out of 10, it's unethical to use a placebo because we can't withhold, active therapies from patients and, have that be ethical. It's just not. by and large. But in some rare instances where we've got no drug in that space that's approved by the FDA or has known activity, it's okay to use. So in that ADORA trial, the patients had their cancer resected. That was the standard of care. The patients had their chemotherapy, in some cases, they were always offered it, but not everybody took it. They had that offered to them because that was the standard of care. And then after they complete those 2 standard of care treatments, nothing would typically happen thereafter. They would move into a surveillance phase. So if a patient's in a surveillance phase and wouldn't normally be receiving therapy otherwise, then it was okay to do that randomization to the targeted therapy or the placebo. But it's not typical to see placebo. So that's a good question.
Okay, great, thank you. And here's another question about that trial. So why don't they start a patient on the next generation drug first before the patient fails from the other drug that they are currently on if the next generation drug works better?
So with regard to that specific trial, I'm not sure that I can quite put that into context, but I guess what I would say is this is a marathon, it's not a sprint. And when we have a patient that is responding to and tolerating whatever drug that they're on, sometimes it can be hard to say, well, let's stop this and switch to option B, because even though new targeted therapy may have a really good outcome in clinical trials, I didn't show you any drug today that had 100% response rate and 100% benefit. So if you're on something and you're responding to it, you may decide, in communication with your care team, that it's better for you to stay on that drug, ride it out for as long as we can, and then switch later, knowing that you have a good next plan. I like to have plan B and sometimes even be thinking about plan C.
Okay, great, thank you. So here's another question about Tagrisso. Everyone was really interested in that portion. Okay, this person had concern about what happens if there's a recurrence anyways? Is Tagrisso off the table, or can it be reintroduced further down the line in terms of their treatment plan?
Oh, meaning if the patient completed the 3 years of the Tagrisso on trial, came off the Tagrisso, so of course, yes. Yes, the Tagrisso could be reintroduced at that point. My guess is that upon recurrence, kind of depending upon the timing, the care team might recommend a new biopsy, either a biopsy of the tumor or a liquid biopsy, to be sure that's what's driving the tumor. And if so, they may pull that out of the toolbox, or there are other drugs that could be appropriate.
Okay, that's great. And this question is kind of in that vein, the next one. Can cancer cells mutate or transform to small cell or another mutation with chemo like they do with targeted therapies?
The main space that we have seen a cancer cell transform from a non-small cell to a small cell, and it's very rare, but is something that I almost didn't believe the first time I heard it, is in the patients who become resistant to EGFR targeted therapies. It's not common. It kind of illustrates why we can't always just get a blood, liquid biopsy, and sometimes we need to actually stick that needle in the tumor to understand if it's converted. That's the primary space that we might see that. And it's not every patient who becomes resistant to EGFR targeted therapy that develops small cell. This is just one possibility. But I'm not aware of cancers changing histology in the non-targeted therapy space.
Okay, great. Thank you.
Yeah.
Another question, can PDL levels change over time?
Yeah. I think probably more what it is, if a PDL level changes from one sampling to the next, maybe just that, and that is sampling. Depending upon where the needle was stuck in the tumor, sometimes there can be variability, and it may change over time. I think kind of this is why, and this is one of the biggest challenges of lung cancer clinical trials, is that they often require multiple biopsies. one at baseline and then one upon progression to see what is that PDL1 doing, what are other immune therapy targeted biomarkers doing. And it's a really hard thing to consent to as a patient because it's not always easy to get a tumor biopsy. It may require another bronchoscopy or a liver biopsy. I mean, who wants to have a liver with a needle in it? And so we oftentimes have these requests of clinical trials that say tumor biopsy at 6 weeks, encouraged but not mandatory. Sometimes it's mandatory, and a patient would have to understand that when they consent at the beginning. But I think we're missing a lot of information upon tumor progression because of the need to get more tissue. And so, as we gather more data over the years from more patients, I think we'll have a better understanding of what happens to PDL1 over time.
Great, thank you. And this is the last question that I have, but someone here has a friend with the G12F mutation, which she says is very rare and there are no treatments. She's been on one trial after waiting for the right treatment. Do you have any updates for that mutation specifically off the top of your head?
You know what, I don't. I have a couple of patients in my practice with the G12F, and it's like, if you're playing the lottery and you see 21, yes, 7, yes, you're reading left to right and you're like, a match, am I going to be the big winner? And then there's an F at the end and you're like, oh no, it's not this, So no, unfortunately I don't. So close, but I would say, keep looking. Maybe there are other trials out there that I don't know about. And certainly chemotherapy can have activity in this space. Immune therapy can have activity in this space. For sure. So just because there's not a targeted therapy for G12F doesn't mean that there's not hope or treatment options.
Awesome. Well, thank you. And I mean, there is so much hope. All of these drugs you're talking about have been approved by the FDA just in the past year or two for the most part. I noticed that as a theme throughout your slides. So it's really exciting, and you definitely have your work cut out for you keeping up with all of these advancements. So thank you for sharing all of that information with us, because it's important for us as advocates to have all of that information as well. So thank you so much for your time, Dr. Lee. It was really a wonderful presentation.
Thank you. I'm here if anybody wants to email me questions afterwards, or Tama can help connect them to me. I'm going to put myself on mute and hang around for a little while longer, if that's okay.
That's great. Yeah, please do. And Paige, I'll turn it over to you to transition to our next speaker.